Hello everyone! Today, we are from Group Dr. Halimsi will be presenting about rheumatoid arthritis. And this is our group member. There are Pilain, Aina, Nurshamin, Abirami, Atiatul, and Sofia Balkis. Let me show you first about our learning outcomes. First, we'll explain about the pathogenesis of rheumatoid arthritis. Second, we'll describe the morphological features and clinical presentations of rheumatoid arthritis. Third, we'll describe the therapeutic objective in the treatment of rheumatoid arthritis. And fourth, classify drugs used in the treatment of rheumatoid arthritis. And last, we'll describe the role of steroid, NSAIDs, and the MRRDS in the treatment of rheumatoid arthritis. Now, we're going to the introduction.
Introduction on rheumatoid arthritis. What is rheumatoid arthritis? It's a chronic autoimmune disease characterized by the inflammation of the synovial joint. RA usually manifests as symmetrical polyarthritis, but also present with nonspecific symptoms, for instance, fatigue and mild fever. RA commonly affects wrists, hands, elbows, shoulders, knee, and ankles. Delayed or inadequate treatment will result in bone erosion.
Hello, my name is Atiatul Afiat and I'm going to explain the pathogenesis of rheumatoid arthritis. But before that, what is actually rheumatoid arthritis? So, rheumatoid arthritis is a chronic inflammatory disorder of autoimmune origin that principally attacks the joint and producing a non-suppurative proliferative synovitis. And what is the etiological factor of rheumatoid arthritis? The etiological factor can be divided into genetic predisposition and environmental factor. Example of genetic predisposition is human leukocyte antigen, anti-citrullinated protein antibodies, and rheumatoid factor. And example of environmental factors such as cigarette smoke and pathogen. So, rheumatoid arthritis is triggered by the interaction between genetic factor and environment. For example, a person with a gene for immune protein like human leukocyte antigen or HLA-DR1 and HLA-DR4 might develop rheumatoid arthritis after getting exposed to something in the environment like cigarette smoke or a specific pathogen like bacteria. This environmental factor can cause modification of our own antigens such as IgG antibodies or other protein like type 2 collagen or vimentin. Type 2 collagen and vimentin can get modified to a process called citrullination. That's when the amino acid arginine found in this protein is converted into another amino acid which is citrulline. Meanwhile, due to the susceptibility genes HLA-DR1 and HLA-DR4, immune cells sometimes are not clever enough, so they get confused by these changes, and they no longer recognize this protein as self-antigen. Then, the antigen get picked up by antigen-presenting cells and get carried to lymph node, and it binds to CD4 T helper cell. CD4 T helper cell become activated by antigen-presenting cell through interaction between the T cell receptor and class II MHC peptide antigen with co-stimulation through the CD28-CD80 pathway, as well as other pathways. T helper cells then stimulate the nearby beta cell to start proliferating and differentiate into plasma cell which produce specific antibodies against self-antigens. Synovial CD4 T cells then differentiate into T helper 1 and T helper 17 cells. In rheumatoid arthritis, T helper cell and antibodies enter the circulation and reach the joints. Once there, T cells secrete cytokines like interference gamma to recruit more inflammatory cells like macrophages into the joint space and also to activate the synovial cell. Macrophages will also produce inflammatory cytokines like tumor necrosis factor or TNF-alpha, interleukin-1, and interleukin-6, which together with the T cell cytokines stimulate synovial cells to proliferate. The increase in synovial cell and immune cell will create a pannus, which is a thick swollen synovial membrane with granulation of scar tissue made up of fibroblasts, myofibroblasts, and inflammatory cells. Over time, the pannus can damage cartilage and other soft tissues and also erode the bone. The activated synovial cells also secrete proteases which break down the protein in the articular cartilage, and without the protective cartilage, the underlying bones are exposed and can directly rub against each other. In addition, inflammatory cytokines increase a protein on the surface of T cells, which is known as RANG-L, or receptor activator of nuclear factor kappa B ligand. RANG-L will allow the T cells to bind to a RANG, which is a protein on the surface of osteoclasts, to get them to start breaking down bone. Meanwhile, antibody also enter the joint space. And there's another one antibody called rheumatoid factor, or RF, which is an IgM antibody that target the constant Fc domain of altered IgG antibody. Another antibody is anticyclic citrullinated peptide antibody, or CCP, which targets citrullinated proteins. When these antibodies bind to their target, they form immune complexes which accumulate in the synovial fluid. There, they activate the complement system, a family of 9 small proteins that work in an enzymatic cascade to promote joint inflammation and injury. Finally, the chronic inflammation causes angiogenesis, or the formation of new blood vessels around the joint, which allows even more inflammatory cells to arrive. As the disease progresses, multiple joints on both sides of the body get inflamed and gradually destroyed. So, that's all for the pathogenesis of rheumatoid arthritis.
Moving on to TLO number 2, morphological features and clinical presentation of rheumatoid arthritis. Assalamualaikum and hi everyone. I'm Sofia Balkis. In this part of my presentation, I would like to talk about the morphological features of rheumatoid arthritis. First of all, let I shortly brief what is exactly rheumatoid arthritis. Rheumatoid arthritis, which also called as symmetric arthritis, it is because symmetric arthritis affects the same joints on both sides of the body, such as knees or wrists. Morphologically, joint inflammation in rheumatoid arthritis begins with synovial membrane and extends to the cartilage and subchondral bone level. This eventually leading to destructive changes of the joint. This feature clearly differentiates rheumatoid arthritis from osteoarthritis that starts at the joint level and in which the synovial membrane is secondarily affected, and some septic arthritis in which the first change in the bone marrow. In early rheumatoid arthritis, first changes occur is in the synovial membrane, which developing more an unseparated proliferating synovitis. At the onset of illness, for a short period of time, acute inflammatory changes occur. If the process continues, the acute inflammatory response is rapidly replaced by chronic inflammation that is characteristic to rheumatoid synovitis. Thus, if at the beginning the synovitis type is exudative, it will quickly progresses to a proliferative infiltrative appearance. As we can see the diagram that I attached with, the synovium becomes edematous, swollen, hyperplastic, and changing its smooth contour into one covered by fragile and bulbous villi. Then, I will move on to the stage of rheumatoid arthritis. For the stage 1, Before rheumatoid arthritis becomes clinically apparent, the immune pathology is already beginning. There is a rise of ESR, which stands for erythrocyte sedimentation rate, C-reactive protein, and rheumatoid factor. Stage 2, there is a vascular congestion with new blood vessel formation, proliferation of synoviocytes, infiltration of the subsynovial layers by polymorph lymphocytes and plasma cells, and there is a thickening of the capsular structures, villus formation of the synovium, and a cell-rich effusion into the joints and tendon sheath. Stage 3, there is a mass of edematous synovium, inflammatory cells, granulation tissue, and fibroblasts that grows over the articular cartilage and causes its erosion. In stage 3 also, there is a pannus formation. In a healthy joint, the smooth synovium is just a few cells thick. The synovium produces synovial fluid, which lubricates and nourishes a joint. Rheumatoid arthritis causes white blood cells to attack healthy synovium. This attack is the start of inflammation. The white blood cells then release chemicals, which known as cytokines, that induce the synovium's blood vessel to multiply, as we call it as hypervascularization. As blood vessels multiply, blood flow will increases. The increased blood flow encourages synovium cell to multiply. As more cells are produced, the synovium thickens. Meanwhile, microscopic finger-like projections grow on the normally smooth surface of the synovium. These projections, called villi, make pannus tissue rough and uneven. The thickening synovium requires space and invades the space in between a joint's bones. It spreads over the surface of the bones and their protective layer of articular cartilage. It also pushes out at the edges of the joint, making it look swollen. And last but not least, in stage 4, the damaged joint area starts to fuse with a connective fibrous tissue. This stage also causing articular destruction, capsular stretching, and tendon rupture that leads to progressive instability and deformity of the joints. This will severely limit range of motion, which may make simple tasks even more difficult. At this point, the joints may start to appear bent and crooked. Inflammatory process usually continues, but mechanical and functional effects of joint and tendon disruption now become vital. Next, we move on to histologic feature changes in rheumatoid arthritis. The characteristic histologic features include synovial cell hyperplasia and proliferation, dense inflammatory infiltrates of CD4 plus helper T cells, B cells, plasma cells, dendritic cells, and macrophages. With that, I attach a diagram that shows all the elements. Next, increased vascularity resulting from angiogenesis. Neutrophils and aggregates of organizing fibrin on the synovial and joint surfaces. Osteoclastic activity in underlying bone, which allowing the synovium to penetrate into the bone and causing periarticular erosions and subchondral cysts. Together, the all changes will produce a pannus. In advanced untreated cases, the panels can breach the bones to form a fibrous ankylosis, which may later ossify as a bony ankylosis. In addition, rheumatoid nodules are an infrequent manifestation of rheumatoid arthritis and typically occur in subcutaneous tissue, including the forearm, elbows, occiput, and lumbosacral area, and microscopically, they resemble necrotizing granulomas.
Hi, my name is Aina Nabila and I'll be presenting about the clinical presentation. There are two categories, which are articular manifestations and extra-articular manifestations. In the early stages, RA begins slowly with malaise, fatigue, fever, weight loss, and myalgias. After several weeks to months, active inflammation of joints started to appear. The pattern of joint inflammation is generally symmetrical and most commonly affect the hands and feet. It may also involve any joint lined by a synovial membrane. The metacarpophalangeal and proximal interphalangeal joints are frequently involved. Involved joints are swollen, warm, and painful, and there will be loss of mobility. Patients will also experience morning stiffness, which can be improved with activities. In the later stages, patient typically has progressive joint enlargement and decreased range of motion. Narrowing of the joint space, loss of cartilage, and osteopenia can be seen. Joint deformities are developed due to misalignment, resulting from swelling, progressive joint destruction, or partial dislocation. Examples of joint deformities of the hand includes boutonniere deformity, ulnar deviation, and swan neck deformity. For the knee, we have bilateral knee valgus, and on the foot is hallux valgus, also known as bunion, and hammer toe. Next, we will be looking at the extra-articular manifestations. For skin manifestation, it includes rheumatoid nodules, palmar erythema, and skin ulceration. For ocular manifestations, keratoconjunctivitis sicca, also known as dry eye syndrome, is common in RA patients. The eye may also have episcleritis. RA involvement of the lungs may take several forms, including pleural effusion and lung fibrosis. Cardiovascular disease such as myocardial infarction and pericarditis can also be observed in RA patients. Some patients with active RA develop anemia with chronic condition. Neurological manifestations such as peripheral neuropathy can also be seen, as well as carpal tunnel syndrome.
Now, let's look at lab investigation for rheumatoid arthritis. As there's no cure for rheumatoid arthritis, there is the other option that can help manage the symptoms. There is no test that can confirm a diagnosis of rheumatoid arthritis. However, multiple blood tests can indicate rheumatoid arthritis. For the first blood test is erythrocyte sedimentation rate. An ESR test evaluates how much inflammation is present in the body. The test measures how quickly the red blood cells, that is called as erythrocytes, separate from your other blood cells in a lab when they are treated with a substance that prevents clotting. Red blood cells clump together when there's inflammation in the body, making them separate from the other blood cells much faster. Low ESR levels indicate low levels of inflammation, while high ESR results indicate high levels of inflammation. Doctors use this test to diagnose rheumatoid arthritis because this condition causes inflammation throughout the body. An ESR test on its own, however, is not enough to diagnose rheumatoid arthritis. Inflammation and a rise in ESR levels can be caused by other chronic conditions and by infections or injuries. However, your ESR rate can help point doctors in the right direction. For example, Elevated ESR levels would likely indicate an infection and not rheumatoid arthritis. Second lab task is C-reactive protein. A CRP test looks for the amount of CRP protein in the bloodstream. CRP is a protein produced by the liver. Liver releases CRP when there's an infection in the body. CRP helps start the immune system response to the infection. This leads to inflammation throughout the body. Autoimmune conditions such as rheumatoid arthritis can result in high levels of CRP in the bloodstream. A CRP test measures CRP and indicates the presence of inflammation. Similar to an ESR test, a CRP test cannot confirm rheumatoid arthritis on its own. However, it can give doctors a good idea of how much inflammation is present in the body and how active your immune system is. Next, full blood count. A full blood count, also known as a complete blood count, evaluates the cells that make up your blood. This includes white blood cells, red blood cells, and platelets. When you are healthy, our body can make, release, and regulate the amount of each type of blood cell that we need for our body functions. Rheumatoid arthritis doesn't typically cause a disruption to the blood cells, but many conditions with similar symptoms do. A complete blood count with very abnormal results might indicate rheumatoid arthritis is not the right diagnosis. Rheumatoid factor tests. Rheumatoid factors are immune system proteins that sometimes attack the healthy tissue in the body. A rheumatoid factor test measures the level of rheumatoid factor proteins in the bloodstream. High level of rheumatoid factors often point to rheumatoid arthritis, as well as Sjogren's syndrome and other autoimmune conditions. Results that show a high level can be helpful in confirming a rheumatoid arthritis diagnosis. However, people without autoimmune conditions sometimes have a high level of rheumatoid factor proteins, and not everyone with rheumatoid arthritis has a high level of rheumatoid factor proteins. Cyclic citrullinated peptide CCP antibodies are a type of immune system protein called an autoantibody. Autoantibodies are abnormal proteins that attack healthy blood cells and tissues. Between 60 and 80% of people with rheumatoid arthritis have CCP antibodies in their blood. An anti-CCP antibody test, also called an ECCP test or CCP test, looks for the presence of these antibodies to help confirm rheumatoid arthritis. An anti-CCP test can also help doctors determine the severity of a rheumatoid arthritis case. High levels of CCP at diagnosis indicate an increased risk for the fast progression of joint damage. Doctors typically perform both a rheumatoid factor test and an anti-CCP test when evaluating a person they suspect may have rheumatoid arthritis. A positive result for either test indicates a higher risk for rheumatoid arthritis, and that risk is increased when both tests are positive. Anti-nuclear antibodies. ENA are a type of autoantibody produced by our own immune system. They act abnormally and attack healthy tissues and cells. The presence of ENAs can indicate an autoimmune condition. ENA testing looks for the presence of ENAs and can help confirm a rheumatoid arthritis diagnosis. Blood tests are not the only method that can be used to diagnose rheumatoid arthritis. You might also have a variety of other tests done to help confirm rheumatoid arthritis. These include joint scan. A joint scan looks for inflammation and damage in your joints. It can help confirm a rheumatoid arthritis diagnosis. Next, imaging tests. X-rays and MRIs create detailed pictures of your bones, muscles, and joints that can help diagnose rheumatoid arthritis. Well, this brings me to the end of my presentation. Thank you.
Next, I will be talking about complications of rheumatoid arthritis. RA itself is not fatal. However, complications of the disease may shorten life expectancy by years in some individuals. Some of the complications include infection. Patients with RA are at greater risk for infections, especially those who are taking immunosuppressive drugs. Next is GI problems. Patients with RA may experience stomach and intestinal distress. Another complication includes osteoporosis. The hip is particularly affected. This condition is most common in postmenopausal women with RA. The risk of osteoporosis appears to be higher than average in men with RA who are older than 60 years. Another complication is Sjogren syndrome. Keratoconjunctivitis sicca is a common complication of RA, while oral sicca and salivary gland enlargement are less common. We also have Felty syndrome. This condition is characterized by splenomegaly, leukopenia, and recurrent bacterial infections. It may respond to DMARDs, which is a short form for disease-modifying anti-rheumatic drugs. Last but not least is lymphoma. RA-associated immune system alterations may play a role in increasing the risk of lymphoma. Aggressive treatments for RA may help prevent such cancers. As for the prognosis of rheumatoid arthritis, treatment can slow down the progression of the disease. It can also help reduce pain, make symptoms manageable, and prevent joint damage. A person's prognosis depends on many factors including their age, disease progression, any complications, and lifestyle factors. It is difficult to predict the exact effect that RA will have on a person's life expectancy because the course of the disease differs significantly among individuals. In general, it is possible for RA to reduce life expectancy by around 10 to 15 years. However, many people continue to live with their symptoms past the age of 80 or even 90 years. People with advanced RA have a significantly lower life expectancy than those who have less active RA. This is because advanced RA is often accompanied with severe complications. So that's it for TLO2. Moving on to the next presenter.
In this TLO, I'll be describing the therapeutic objectives in the treatment of rheumatoid arthritis. Now, let us understand why treatment of rheumatoid arthritis is important and what are the objectives in giving treatment to these patients. Rheumatoid arthritis that causes swelling at the joints will continue to progress without any treatment. The inflammation will increasing and eventually cause joint deformity. Hence, rheumatoid arthritis symptoms will get worsened and lower quality of life, damage the joints, and damage vital organs. Let's see the current treatments to manage rheumatoid arthritis. As we all know, unfortunately, there is no cure for rheumatoid arthritis available. However, with the current treatment that are available such as medications, biosurgery, physical measure, and also lifestyle measure, it will help to reduce inflammation, pain, and also prevent joint and major organ damage. Treatment by medications depends on the prescription of doctor for severity and times the patient have rheumatoid arthritis. First, in steroid, example are hydrocortisone, prednisone, methylprednisone. This will reduce pain and stiffness in the patient. Next, In non-steroid anti-inflammatory drugs (NSAIDs), examples are ibuprofen, naproxen, celecoxib. These drugs helps to reduce or relieve inflammation and also reduce pain. It is important to remember that celecoxib need doctor prescription because it is stronger compared to other drugs. Third medication used in rheumatoid arthritis patients are disease-modifying anti-rheumatic drugs (DMARDs). Examples of DMARDs drugs are methotrexate, leflunomide, hydrochloroquine, and also sulfasalazine. All these drugs helps to slow down or prevent progression of rheumatoid arthritis and eventually prevent joints and other tissue from permanent damage. In RA patients, the most preferable drugs are methotrexate. Secondary treatment of rheumatoid arthritis is by surgery. Surgery may be considered only if drug therapy is unsuccessful. Surgery always be done while the disease is active. This surgical treatment helps to reduce pain, restore joint damage, and also improve joint function. For example, in synovectomy, removal of inflamed lining of the joints helps to reduce pain and improve flexibility of the joints. Next, in tendon repair, rupture and loosen tendon around joints caused by the inflammation and joint damage will repair and restore joint functions. Next, total joint replacement. Replace damaged joint with prosthetic joint made of metal and plastic. This total joint replacement surgical helps to repair and restore joints function. When there is no option for joint replacement, joint fusion will take place. This helps to stabilize and realign damaged joints and relieve pain in rheumatoid arthritis patients. Third treatment is by physical measures. Exercise is important to improve and keep joints flexibility, improve muscle function, and reduce stiffness and muscle spasm. During acute inflammation, passive range of motion exercise helps to prevent flexion contractures. The fourth treatment of rheumatoid arthritis are by changes the patient lifestyle. First, it is important to have quality of sleep because it can help to reduce pain. Second, having nutritious diet helps to reduce weight for rheumatoid arthritis patient with diabetes, and also it will maintain the patient to be physically active. Quit smoking are important to improve quality of life, whereby it will further reduce damage on the body. Lastly, consumption of omega-3 fatty acid can be said as a new treatment of rheumatoid arthritis. Consumption of omega-3 fatty acid, example in fish oils, for dietary omega-6 fatty acid, such as in meats, partially relieves symptoms and also reduce inflammation in some of the rheumatoid arthritis patients. And that is all the importance and objective of the treatment in rheumatoid arthritis. I will pass to the next TLOs.
My name is Abhirami Subramaniam. Today I'll be talking about classified drugs used in the treatment of rheumatoid arthritis. Classified drugs used in the treatment of rheumatoid arthritis. The goal of RA treatment is to suppress inflammation, control symptoms, and prevent joint damage. Let's talk about the drugs that are used in the RA treatment. We can classify the drugs into three categories that are non-steroidal anti-inflammatory drugs (NSAIDs), disease-modifying anti-rheumatic drugs (DMARDs), and corticosteroids. Let's first look at NSAIDs. It is commonly used to treat rheumatoid arthritis. It is used as analgesic, control pain, as antipyretic, control fever, and as anti-inflammatory, control inflammation. They do not slow down the disease, so they're usually taken together with DMARDs. For instance, methotrexate to prevent further joint damage. NSAIDs can be further divided into two categories, that is selective and non-selective. Selective NSAIDs are meloxicam and atorecoxib. Non-selective NSAIDs are ibuprofen and ketoprofen. Next classification is DMARDs, and it is further categorized into four. Firstly, conventional synthetic DMARDs. It usually takes up to 8 weeks to exert their effect, thus we combine therapy with corticosteroid. Methotrexate is an example of conventional synthetic DMARDs and used as the gold standard, meaning it is used as the first-line disease-modifying anti-rheumatic drug. Next will be target synthetic DMARDs and biologic DMARDs. Both are effective in early onset and established RA and should be considered when treatment target is not achieved with conventional synthetic DMARDs. The last type of drug that are being used in rheumatoid arthritis are corticosteroid, for instance, cortisone, hydrocortisone, and prednisolone. Prednisolone is preferred over other long-lasting corticosteroids like betamethasone or dexamethasone because it causes less inhibition of hypothalamic pituitary adrenal axis. But we need to consider long-term use of this drug because long-term corticosteroids predisposes to several complications such as osteoporosis and infection. Therefore, it is commonly supplemented together with calcium and vitamin D and regular surveillance for infection.
Hello everyone, my name is Pilayin. So we'll go to the last TLO, which is the role of steroids, NSAID, and the MIRDS in the treatment of rheumatoid arthritis. Firstly, I'm going to explain the role of NSAID, which is non-steroidal anti-inflammatory drugs. Usually, NSAIDs such as aspirin, celecoxib, ibuprofen, and others are used to provide symptomatic relief from joint pain, stiffness, and swelling. All of these drugs just reduce the symptoms but do not alter the course of rheumatoid arthritis. Now, let me tell you how the actions of these drugs. In our body, we have an enzyme that involved in the synthesis of prostaglandin, which are cyclooxygenase 1 and 2, or we also call COX1 and COX2. The role of prostaglandin in inflammation is to produce vasodilations, increase vascular permeability that cause an edema and can lead to swelling, and also sensitize specialized nerve endings to the pain mediators. So, the NSAIDs will inhibit both cyclooxygenase enzyme and inhibit the synthesis of prostaglandin, which can reduce the symptoms of inflammation such as pain and swelling in rheumatoid arthritis. Let's go to the second one, is steroid anti-inflammatory drug, which is highly potent anti-inflammatory if compared with NSAIDs. So, we have prednisolone, which is the one of glucocorticoid that frequently used to suppress inflammations and immune responses in rheumatoid arthritis. This drug will stimulate the synthesis of leukocytes of a protein which is annexin 1 that inhibits phospholipase A2. Phospholipase A2 is an enzyme located in the cell membrane which is activated in damaged cells and is responsible for the formations of arachidonic acid, which is the precursors of many inflammatory mediators such as prostaglandin, leukotrienes, and platelet activating factors or PAF. And also, it will inhibit leukocyte infiltrations at the site of inflammations, interfere with mediators of inflammatory response, and suppress humoral immunity at autoimmune disorder such as rheumatoid arthritis. The third one is disease-modifying anti-rheumatoid drugs, which are a group of medication that should be given as early as possible after provisional diagnosis of rheumatoid arthritis. It's divided into two groups, which are biologic and non-biologic drugs. Now, we are going to biologic disease-modifying anti-rheumatoid drugs. Why it's called biologic is because they are made from proteins. It's divided into TNF inhibitor and non-TNF inhibitor. Agents of these drugs include adalimumab, certolizumab, golimumab, infliximab, and etanercept. As you can see, all of these drugs end with MAB except etanercept, that we can know the difference after this. So, the drugs that end with MAB, it's mean monoclonal antibody. At their actions, monoclonal antibody will bind and inhibit the TNF, which is a protein cytokines, a tumor necrosis factor that floating in the plasma that produced by the macrophages and work as inflammatory mediators in rheumatoid arthritis. So, when the monoclonal antibody bind and inhibit the TNF, it will decrease the symptoms of rheumatoid arthritis. Usually, this drug combined with methotrexate for the treatment of rheumatoid arthritis. The next one is etanercept, which is not a monoclonal antibody. Etanercept acts as a decoy receptor for TNF. It means this drug acts like sponge that collect all the TNF from the serum and then engulf and remove the TNF, and it will decrease the symptoms of rheumatoid arthritis. All of these drugs have same side effects such as infections, tuberculosis, and varicella zoster virus, and it also drug-induced lupus and can cause skin rashes, and infusion reactions at the site of injections, and it also causes CNS demyelinations, and also increased risk of lymphoma if contact with azathioprine or AZA. The next one is agents of non-TNF inhibitor. It include abatacept, tocilizumab, rituximab, and anakinra. Usually, the actions of this drug are the same, that will reduce the symptoms of rheumatoid arthritis. The first one is abatacept. It's selective T-cell co-stimulation inhibitor. The side effects is infections of tuberculosis and varicella zoster virus, and also chronic obstruction pulmonary disease exacerbations. The second one is interleukin-6 inhibitor. Is the refractory to TNF disease-modifying anti-rheumatoid drugs. The side effects is infections of tuberculosis and varicella zoster virus, myelosuppressions, and hyperlipidemia. The third one is rituximab. It's monoclonal antibody against CD20 B lymphocytes, usually combined with methotrexate in treatment of rheumatoid arthritis. The side effect is toxic epidermal necrolysis, tumor lysis syndrome, and acute respiratory distress syndrome. The last one is anakinra, which is the interleukin-1 inhibitor. The side effect is infections of tuberculosis and varicella zoster virus. All of these drugs have contraindications, which are if patient has an infection and before a major surgery. Now, we enter to the non-biologic disease-modifying anti-rheumatoid drugs. The first one, we have methotrexate. Methotrexate is the first line of disease-modifying anti-rheumatoid drugs that used for rheumatoid arthritis. It's a folic analog that usually given as one weekly dosing orally or subcutaneous, and also intrathecal in the case of cancer. Usually, it can be used alone or combined with another drug such as NSAIDs, steroid, biologic DMARDs, and other non-biologic DMARDs such as sulfasalazine and hydrochloroquine. Let me explain you about the mechanism of actions. As we know, methotrexate works by inhibiting the hydrofolate reductase, which is an important enzyme in the synthesis of nucleotides. Folic acid from our diet is converted to the hydrofolate, and the hydrofolate will be converted into tetrahydrofolate through the dehydrofolate reductase. And tetrahydrofolate will be converted into 5,10-methyl tetrahydrofolate, and 5,10-methyl tetrahydrofolate will be converted again to the dehydrofolate through the enzyme thymidylate synthase. At the same time, it's also producing thymine, which is part of the nucleotides that required for the DNA synthesis. In these conditions, methotrexate will inhibit the hydrofolate reductase and also thymidylate synthase, leading to decreased synthesis of thymine that required for DNA synthesis, and it will cause inhibitions of nucleotide synthesis and prevent cell division. Methotrexate polyglutamate inhibits the enzyme called aminoimidazole carboxamide ribonucleotide transformylase or AICIRT more than methotrexate. This IACIRT is important in the conversion of IACIRT to IMP, which is the precursors to purines, adenines, and guanine, which are required for DNA and RNA synthesis, and it will reduce the development of rheumatoid arthritis. Inhibition of AICART, it will reduce the purine nucleotides and also cause accumulations of IACIRT, which inhibits adenosine deaminase, leading to an accumulation of adenosine triphosphate and adenosine in the extracellular space, stimulating adenosine receptors and leading to anti-inflammatory reactions. The usage of these drugs has several side effects such as hepatotoxicity, GI hemorrhagic enteritis, and bone marrow suppressions, which can lead to the cytopenia or macrocytic anemia. The other non-biologic disease-modifying anti-rheumatoid arthritis are rare to use, and some of them has unknown mechanism. The second one is sulfasalazine. Sulfasalazine split in the colon by bacteria to produce sulfapyridine and the active components 5-aminosalicylic acid. The functions is suppress inflammatory activity of rheumatoid arthritis, usually used together with the methotrexate. The third one is penicillamine. The mechanism of action is unclear, but may involve inhibition of interleukin-1 productions. The beneficial effects of this drug usually show after 7 months. The third one is hydroxychloroquine. This drug less effective than other drugs in the treatment of rheumatoid arthritis, but is used as an adjunct with other disease-modifying anti-rheumatoid arthritis such as methotrexate, and the mechanism is also unknown. Last but not least, gold as sodium aurothiomelate. This drug is given by intramuscular injections. The beneficial in rheumatoid arthritis develops slowly, the maximum effect being seen after 4 until 6 months. The mechanism is unclear, and the adverse effects are common and include rashes, blood disorders, and proteinuria. So that's all for me. Let's proceed to the next slide. Thank you.
In conclusion, we have discussed the pathogenesis of rheumatoid arthritis, the morphological features and clinical presentation of rheumatoid arthritis, the therapeutic objective in the treatment of rheumatoid arthritis, the drugs used in the treatment of rheumatoid arthritis, and the role of steroid NSAIDs and DMARDs in the treatment of rheumatoid arthritis. So that's all from us. Thank you.